Okay, thank you for joining our first open lecture series of the summer semester. It is with great appreciation that I share tonight's speaker, Stephen May, with you all tonight. He has been practicing pastoral counseling and psychotherapy for over 20 years. He has worked with site care consultants in South St. Louis County since 2008. He's also a former employee of Centerpoint Hospital. He's done residential work, and he currently owns his own practice in St. Louis. He was trained, which is an additional training in the technique of EMDR in 2016, and he has used the EMDR in conjunction with other forms of therapy for patients experiencing trauma, loss, and grief. His education is also impressive. He received his master's degree in marriage and family counseling from the Alder University in Chicago, Illinois. And following the completion of his degree, he trained for an additional 2 years and received certification in Jungian psychotherapy at the Jungian Institute in Chicago. And so without further ado, I'm going to hand it over to my friend, my colleague, and one of my mentors when I first started, and continue today to be my mentor. So I'll hand it over to Steve.
Okay. Well, hello, and I'm Steve, and I'm going to talk to you a little bit today about EMDR, which is eye movement desensitization and reprocessing. This is a technique as well as a therapy. I predominantly use it as a technique more than it being the only therapy that I use or my primary theoretical orientation. EMDR is a technique that has tremendous empirical validity. It's been used by Veterans Hospital system for probably well over 20 years and has significant success rates in its use and effectiveness. So we're going to be talking a little today about EMDR, and what I hope to do in terms of objectives is that you have a basic understanding of EMDR and its use in clinical settings, understand what bilateral stimulation BLS is and how it impacts the process of recollecting a traumatic event, understand the requirements for receiving training and supervision in the use of EMDR. Okay. This is the primary person who developed the theory of the use of eye movement desensitization and reprocessing. She has passed away, I think, in the last 2 years. Her name was Francine Shapiro. If you wanted to read like, the Bible of EMDR, this is where you would start, is with Francine's publication to understand the theory and the technique and how it is used with folks who suffer from trauma and or significant loss. And by the way, I didn't mention this. It says somatoform disorders. I switched that around on Brandy here in the last minute. So we're going to go with EMDR and trauma instead of the somatoform disorder. So this would be the book that you would take a look at if you want a good, strong foundation in EMDR. So trauma, we're going to talk a little bit about PTSD for a moment. What happens with PTSD, literally, this is happening literally within the brain, is when you have a traumatic experience, that experience is so overwhelming that it ends up getting sealed off in a portion of the brain. In fact, when we do MRIs and take a look at people recollecting traumatic memories, what we see is in the brain is in the neocortex, it kind of looks like you're flying over a small town in Kansas. You're flying further, and if you went through Kansas or Nebraska, you have long periods where it's just pitch black dark. And then we get back here to the amygdala, and it is on fire, as if, and I use this as an example, you're flying into Vegas and it's been dark, 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 and all of a sudden this magnificent amount of light appears as you're flying into Las Vegas. Same thing is occurring with the brain when someone is recollecting a trauma. Very little activity in the neocortex, amygdala is on fire. So literally what happens when you experience a trauma is that the thinking part of the brain gets separated from the feeling part of the brain. And the reason for that is, just like any other sort of physiological response, that's the way the brain deals with the shock of the trauma. So the affective portion gets disconnected from the front end of the house here in the neocortex. And so in Greek Roman myth, you have the baby Zeus. His father Kronos is attempting to eat him and his brother, and Zeus is saved by the Carets, which are guardian daemons, as they're referred to in the world of literature. And so what's happening to baby Zeus is he's being protected from a devouring father in the mythology. But by being protected, he is also concealed by these soldiers who will not allow him to get out of that, as you can see, triad. The same thing happens in trauma. What the Carets are in terms of the affective world is anxiety, or those affective experiences or responses that have been disconnected from the thinking part of the brain. Another layer is also shame. Often people who have experienced trauma, the feelings are so overwhelming and out of control. There is a strong layer of shame that covers that disconnected affective part of the experience, so that individuals are automatically directed more toward their internal world than their external world. I can't tell you how many people over the years I've worked with who've experienced a variety of different traumas, whether it was an extreme physical abuse or extreme emotional abuse. They could present as someone who seems very confident and talk about a variety of experiences in a very confident way. But when they begin to talk about their traumatic experience, their eyes will drop to the ground because they're going into their emotional world. And the feedback is being cut off from the outside world, which really mirrors what happens in the physiology of the brain as well. The interaction or new information coming in is blocked, it's cut off, and the person goes into their internal world and often feels or can identify, number one, feeling as though they're frozen when they're re-experiencing trauma or any sort of experience or symptom related to trauma. And the other thing is that incredible amount of shame. So from a Jungian standpoint, which I'll get into the EMDR in a moment, this is what happens with trauma. Anxiety surrounds the trauma. We don't want to be that vulnerable. Our minds, our brains will not allow us to do that. These particular daemon warriors come out and encapsulate that affective experience, which makes it incredibly confusing to the person who is suffering from it, because those locked away affects can be activated by all sorts of different stimuli. Some of it does not even seem to have rhyme or reason to us on the outside, but to the person, there's very clear associations connected to the trauma that they're experiencing. Okay. How I discovered EMDR, the eye movement desensitization reprocessing. I was initially trained as an Adlerian. I also received training at the Gestalt Institute of St. Louis. And so I would dig deep into people's foundational narratives. about themselves, about others, about the world. I'd use the experiential techniques that you would find in Gestalt as a way to express those conflicts or painful narratives in an experiential way. Because another thing that happens with trauma is very hard to put words. And as I said, the neocortex is disconnected from the process. Put words or put meaning to the feelings that the person is experiencing. So expressing what's going on with those feelings within trauma becomes very important. And that sometimes has, and in the case EMDR, often has very little to do with what you're communicating or the words that you're saying. What I would do then is I would take someone as an example. I had a teacher at one point, and they had allowed a student in a room that functionally was probably not appropriate for her classroom setting. The student had attacked her. She had a disability. The student, in a very primitive way, began to bite her, caused her tremendous amount of trauma. You naturally are going to have a feeling of anger, but because of cultural injunction, or the fact that she's a teacher, or the fact that this child was 5 or 6 years old, she was unable to metabolize that experience and it was locked away. So what I would do is I would give her opportunity to express those affects that had been disconnected as a result of that traumatic experience. And that would be done through empty chair techniques or symbolically acting out aspects of the trauma, getting her to notice what was going on in her body, being able to expand on that, whether it was through an expressive means or ultimately then through words. But words were never the primary thing that I would use when I would be treating trauma. This is prior to EMDR. Okay. This is my man crush, Bessel van der Kolk, who I would strongly encourage you to look him up. He is the head of a trauma postgraduate training program related to PTSD. He was the first person that sort of introduced me to EMDR, being at a lecture of his probably about 15 years ago. And so Bessel feels that modalities like EMDR, and he was also on the day that I saw him lecture, was a fan of what was called Hokami, which was a very, they talk about it now as like a sensory motor psychotherapy, but really it was a sensory motor psychotherapy before it became a popular thing. He was very much into words cannot heal trauma. Actions, awareness of bodily sensations, expressions of those sensations are disconnected affects are what is most important. So he showed an MRI and showed me the first image of someone that was reading through a trauma they had experienced. And he would show us the MRIs and show us the fact that the amygdala was on complete fire and that the neocortex played a very little role in the process. He was also famous for having groups where women had been sexually abused. He would get the women in a room, sort of in a circle, bring in the guy with the real big head foam thing. I'm sure you've seen them before. And he would allow the women just to pound on the guy while the other women were cheering them on to pound that guy, as if the woman was symbolically attacking the perpetrator, which ends up allowing those disavowed affects to end up being expressed and not only shifting the conscious or phenomenological experience of the trauma, but also starting to shift the biological frozenness that occurs as a result of trauma. Okay, talked a little bit about Hokami with you, a body psychotherapy. EMDR is the eye movement desensitization and reprocessing. I had also explained to you about the symbolic and reparative sort of group method that Bessel van der Kolk used frequently for those who had been affected by violence or some sort of sexual abuse. Again, some more books to recommend. The Body Keeps the Score, that's an essential one. If you're going to be in the business of mental health, this is an essential reading. because this is the whole idea of how trauma affects the brain and affects the body, and the many ways it affects the brain and the body, and how to access that. And what it says, the body keeps the score. That's really the predominant theory of trauma, that the trauma just isn't in your meaning system, but it's literally embedded in your physiological systems. So as an example, Besser van der Kolk talked about percentages of individuals who suffered or had increased amounts of endocrinology problems as a result of their trauma, because the trauma would ultimately reset parts of the autonomic nervous system, and that would put people at a greater rate of developing disorders, such as, and as a result of, an increase in cortisol. So you all know this much more than me. But you know, our body has a regulating element to it, heartbeat, biochemistry, so forth. What would happen to people who had experienced trauma is their threshold or their set point for controlling cortisol would be messed up as a result of the trauma, and it would often not go back to the setting that it was at previous to the trauma. So van der Kolk would notice that people would have a higher rate of problems with their endocrine system as a result of that. Okay, so Doc the Mule. So I live in the country. I've been out here for about 10 years now, but I'm a city suburban boy. That's the way I was raised. And so learning about all this with trauma in the body, you know, Doc has that mammalian brain, but he doesn't necessarily have the neocortex. He doesn't have the additional piece. And so my friends, who are my girlfriend's cousins, had this mule, and his name was Doc. And we'd go over there on a Friday and Saturday night and hang out and have a fire and hang out in the barn and so forth. And I had worked a lot of hours one day, worked a lot of hours, a lot of days. And I went over and I wanted to go walk over and see Doc, and it was nighttime. And so I went over to see Doc, and he got startled, and he had never really been startled by me before. And what I noticed is I checked myself out first, and I realized that I had just a lot of turbulence going on inside of me. I wasn't very focused. I had worked very long that day, and I wasn't really settled. He could sense that I wasn't settled, and he moved back. He didn't want to come toward me. So did a little mindfulness thing for about 2 or 3 minutes, came back, had reduced all my sort of fight or flight chaos that was going on in my mind at that moment, and Doc came toward me. That's a powerful thing to think about, is that the animal can completely sense where I'm at emotionally, and can sense that that part of my brain, for whatever the reason that day, was very agitated and would not approach me until I had been soothed or re-regulated. This is the same way with trauma. Trauma, the amygdala, the fight or flight system, is completely in a chaotic state. We can, once we move away from the trauma, attempt to suppress it, but we really haven't metabolized the feelings related to the trauma because they're disavowed, they're disconnected. And so then that affect is raw. And depending upon whatever contextual experiences are related to that trauma, that affect can come full forward at full force with what seems to everyone else is no particular reason, because it's operating off of the affective rather than the cognitive. All right. So BLS, what is BLS? I'm going to skip ahead a little bit. That's my cat. He's terrible for BLS. He doesn't comply. But this is what I use online for bilateral stimulation. It's 2 blue dots, and the way EMDR works is you watch the dots. If you don't have the dots or you don't have the machine, you watch someone's hand. That's the way Francine Shapiro wanted people to practice it, is through the visual cortex, because We take in trauma often primarily through the visual cortex, and the visual cortex is the only sensing system that does not seem to have an encoding or decoding process and goes straight into the amygdala. So what you're doing in essence with eye movement, desensitization, and reprocessing is we're taking what is a massive wholesale experience and breaking it down into parts. So I'm just going to demonstrate with my hand, which would be similar with the dots or with the some other type of machine that replicates this. We'll have the person recall the particular traumatic event, and then we'll have them watch. And this is the bilateral stimulation. Now, whether it's my hand or it's these dots, that's the bilateral stimulation. So what's happening is I'm asking someone to recollect the trauma. They're recollecting the trauma. I'm moving my hand. The dots are moving. That's breaking up the experience. So I tell people the trauma is a lot like trying to eat a whole turkey at one time. What EMDR does is it helps you take it and eat it and metabolize it piece by piece. It's almost like by doing this or using whatever mechanism I have, it's cutting it up into smaller frames. Now that's at the surface level, that's what happens with the technique. What's happening is we're doing it as people will have spikes in their anxiety. They'll have certain meanings attributed to the anxiety they're experiencing. So we're constantly testing the waters with the person to see where their disturbance is on a scale of 1 to 10. And then we also want to know what their negative cognition is about the traumatic experience. And so people will have a negative cognition like, I'm not worth it. I'm not worthy to be loved. I have nothing to offer. I am incompetent. I am trash. People will have some negative cognition related to that traumatic event. We gauge that on a scale of 1 to 7. So someone will come in, we'll try to recollect something related to traumatic experience. I'll start off and test where they're at. They'll usually say they're at like a 6 or a 7 is where I usually start at. Find out what their cognition is about that traumatic event, and then get a number from 1 to 7 there. And so then we begin. I implement the technique. We do a set, usually 25 to 30 repetitions. May slow it down, may speed it up. Depends a lot on what's happening with the client and what they're comfortable with. But we'll do a set, do a second set. What I'm asking them to do after the first set is I say, what do you notice now? And usually what's happened with the client is they're focusing on that traumatic event, they're recollecting that traumatic event, and their brain starts to shift a little bit. All of a sudden they notice a smell. All of a sudden they notice something different in the way that they remember it visually. Maybe they notice something in their body that's happening while we're doing the processing. But something else usually starts to shift center stage in consciousness. And what we do is then we go with that. We do another set. So we tend to be, I think, a culture that denies what's going on with our body, which ironically ends up affecting, I think, our traumatic experiences. And so often people may be having a very strong somatic re-experiencing of a trauma. And if we need to move to the body and do nothing but focus on the body, we'll do that. Sometimes we're focusing on the body and something comes up in the cognition. Because they're interconnected, what might be the primary thing in the stage of their experience could shift. It could be in their beliefs. It could be in what comes up next. We do more and more sets and more sets until the numbers come down, till we're down to 0 on the disturbance and down to 0 on the negative cognition. Then what we do is we reinstall a new cognition. So as an example, I am trash. turns to I have worth. Not anything that's futuristic necessarily, just a shift in the here and the now of I have worth. And so the person, then we install the new belief in the same way. It's being installed in the mind, the brain, in the same way that we reduced the experience in the first part of the therapy. Can I jump in and see if anybody's got questions? Is anybody there?
Yeah.
Hello?
Yeah, we hear.
Okay, do you have a question?
No, not like
Hello? Sorry. Are you there? Oh boy. Hi, Musa? Uh,
I don't have questions.
okay, go ahead. Is anyone there?
Yes, we hear.
Oh, go ahead, please.
No, actually,
Ask.
I don't have any questions. I was just saying I'm listening.
Oh, well, thank you. I appreciate it. Is anyone else anything? No? Okay. All right. Okay. Let me back up a little bit. Okay, so this is basically the process that I just discussed with you. We get the history of the traumatic event. We then teach them how to look at what we call TICs, which are images, cognition, sensation, to notice all those parts when they're re-experiencing the trauma, triggers, of course, also. We assess what's going on with the numbers. Then we move toward desensitization and then installation of what the new memory is. And then we have someone, as they're going through the process, as I stated, scan their body. And then we close. And then we reevaluate for where they are at the memory at that point. So those are the phases that we go through overall. We reduce the subjective experience, then we reinstall new experience through the same method of eye movement. There are times when I've had folks who are visual, obviously they've experienced something, but they're more kinesthetic in their orientation. So I will have them watch, but then I will also have them do something like this, tap themselves, which again creates a disruption in the experience because the traumatic experience is like a very solid closed loop. And so when you are watching the eye movement and then tapping, if kinesthetic is a primary way or primary modality, this will affect overall that closed loop and begin to open it up to new information. Okay. Let's see here. Anybody, any questions still? Okay. No questions.
No question. Sorry.
Okay. No, it's okay. For whatever reason, I can't see folks. So I was going to talk a little bit about a case study I had.
Okay.
worked with a guy. And this was a deal in St. Louis. And it happened about probably 3.5, 4 years ago. And the guy doesn't mind me using his situation at all. I'm a little uncomfortable using his name. But he was involved in a prison ministry here in St. Louis, and he was going to school for social work. He was finishing his bachelor's. He was like the president of his class in the social. Happened one bus that they used for the prisoners. And so him and another guy that was with him started throwing eggs at people who were standing at stops. And so they were completely unaware but this other gentleman. And so they were driving around in a van that was clearly marked for the but they were throwing, definite difference in socioeconomic level or in terms of them and the people that they were sort of perpetrating by humiliating and throwing eggs at. And so this individual was picked up by the police. And I remember seeing a picture because I am involved with for years. And I thought, what the heck went on there? And I knew he had had a fairly rough upbringing. I knew he had had a lot of difficulties in his upbringing, but I wasn't aware how much until I really started to work with him. And so initially, what the press was saying was a race against race and so forth and so on. The only problem is that he's Mexican, and his oldest sister is African American and Mexican. So had to look a little deeper than that, than just simply race. And so in assessing what had went on with him, and I'll do this as quickly as I can, he had a mother that had raped all the girls, had them severely and sadistically, had beat them high. When you start to study things like people who are psychopaths and serial killers, there's a defense that they have called omnipotent control, where they like to exercise a sense of like godlike power over another human being. Well, his perpetrator, who was his stepfather, did that frequently and often with him. As a child, would drag him in the basement, put a knife to his neck, tell him if he made any sounds, he and would rape the rest of his female siblings. So this guy had a horrible upbringing, which doesn't justify his actions. His actions are wrong, no matter how you slice it. But we began to work with some of these memories that he had where this guy had exercised this sort of really control over. He was put into like an old VCR like bookshelf, in where there would be two doors and you'd put tapes and books and things. And the man would close those doors off and he'd get his sister to come in with a blow dryer and then blow dry heat into that bookcase. And this is when he was like a 5 or a 6-year-old. And he would be in there having constant panic attacks. Are you there, Brandy? Hi. Can everybody still hear me?
Yes, we
Yeah.
can.
Okay.
I turned,
And so,
I turned my camera off because I thought it was slowing down the connection. Yeah.
okay. And so I end up working with him with the EMDR. And the first first session I did EMDR with him, he started to have recollection of the memory of the perpetrator, perpetrating him. His head and body, it was almost like a very mild reaction, almost like a little bit of a seizure, because that affect all of a sudden had crept in that he had disavowed from himself for years. Ultimately, he said the day that he walked out of jail, he thought to himself, my life is over. I mean, he was on his way. He was a 4.0 student. He went to Assembly God. Why did I do that? Why did I do that? So the long and the short is this, and this is true at a lot of levels, at least where I come from. When someone has abused you in that way, again, there's all these disconnected affects, things like anger, things like rage, things like revenge. And basically what he was doing in his actions is he was sort of that it doesn't for the shame and for all the sadistic sort of abuse that was done to him, but he was doing it through humiliating the people that he was throwing the eggs at. And so it was about being caught off guard, which was definitely part of his experience, being shamed, which was definitely part of his experience. And he was doing this behavior as sort of in psychoanalytic thought, we talk about repetition compulsion. This becomes sort of a repetition compulsion for him, that this is the way that he attempted to reparate for the things that were done to him. But when you look at it from the outside, it clearly is something that's being unconsciously enacted, because why would the guy with the 4.0 social work going on his way to the MSW program be throwing eggs at people at a bus stop? I mean, just at the prima facie of that, something is really wrong there, that somebody's going to screw their whole life up over that. So we end up doing a lot of EMDR. He ended up getting all those symptoms reduced incredibly. It took him about 2 years to get through the court process, 2 years to go back to his denomination. Had to have a whole nother set of sort of accountability, but he did not return to social work. Continues to be in ministry at this point. He's actually a very effective minister. And so that's an example of what EMDR can do. It can take someone that's had very serious, significant trauma and help their brain to heal from that, help them to metabolize those feelings that are naturally going to be they're going to be disconnected and disavowed, because who wants to feel that stuff? Nobody's going to want to feel that kind of overwhelming feeling. No human being is going to desire to experience that overwhelming feeling. They're going to get tucked away, covered in the traumatic experience, unless they're ultimately expressed and metabolized. They're just going to stay there for little moments that you get into where those sort of behaviors may play themselves out. Does anybody have any other questions?
I have a question.
Go ahead.
So Sunny in the chat says can this be used for all age groups? And that kind of dovetails with my question, where is there anyone, someone with a diagnosis of PTSD, is there anyone who would not be a candidate or like ready for this type of technique?
Yeah. Go ahead. I'm sorry. The last part. I apologize.
Oh, just if you could speak to that, if anyone is someone who's not a good candidate for EMDR.
Well, somebody that's actively psychotic is not a good candidate for EMDR. And they'll really have to be in a place where they have some degree of impact, or can have a degree of impact on regulating their affect. The other thing, interestingly enough, is people that have problems with their eyes. So I guess astigmatism, problems or disorders of the eyes, some folks with seizure disorder, not necessarily an appropriate candidate unless their seizures are under control. Those are people that potentially it would not be beneficial for them to do EMDR.
I have just another follow-up question. I'm a nurse practitioner right now, and I know I've heard the stories of trauma from some of my patients.
Yeah.
And of course, I'm not, at a place where I'm trained to do this, but I've also
Right.
inherited a lot of people who are really, really, really medicated. Like
Yes.
they're taking benzos all day long. So is that like a precursor to try to like help them feel before they go into this kind of modality?
Well, I would definitely look at being over medicated as something that could be a problem. And I can tell you, I think at least from Brandy's standpoint, and my standpoint, I'm not a big fan of benzos. So I need them stabilized more of a different way than just with benzos. I know that probably doesn't answer your question, but they just need to be able to have some level of the ability to regulate affect. You follow what I'm saying?
Yeah, thank you. Thank you.
I hope I'm answering it. I hope I'm answering your question. Okay. So, anyone else? No. Okay. So we're going to skip ahead a little bit. How do you do bilateral stimulation? How can you use it just as a way to manage your stress? Since we're away from sort of the traumatic discussion, you get a slinky. Because what's a slinky do? You can hold it in your hand, one end and the other end, and move it back and forth. And so what we'll have people do is watch it as it moves back and forth, incorporating deeper breathing, because as we all know, when someone is experiencing trauma or re-experiencing trauma, that breath is very shallow. So you can take the slinky, move it back and forth, look at it, increase the breathing, and then you can have folks focus on positive messages that are realistic. Not like I'm 10 feet tall and bulletproof, but I am safe. I had a Bosnian lady one time say it in her own language, which was Yiva Shem, I am alive. I am alive. Basic, foundational, anchoring, realistic, real-time sort of statements as you're looking and allowing the bilateral stimulation to sort of open up your brain and take that message in. Hope that makes sense. All right. We're back at questions, comments, or insults. Whatever you would like. Anyone have any questions?
I was wondering, is there any precautions to be taken depending on like what age group you are giving the treatment?
Well, they're using it with small children. In fact, EMDR, which is the organization that I was credentialed through, will go to places throughout the world where there's been war or there's been earthquakes or whatever. They're using it with kids that are 3 and 4 years old. But really, the other things that sort of limit the use of it are the things that I mentioned to the other lady. But it's very easy to use because it's just, we're really working with the physiology more than anything. I would say fundamentally with the eye movement. Does that answer your question?
I was just making sure any difference in precautions, like anything you need to be aware about, or just like extra cautious about while you're providing the treatment.
Well, as I had mentioned, is, someone with a seizure disorder, want to make sure that their seizure disorder is under control. Someone that has an astigmatism or problems with their eyes or visual processing that can aggravate whatever particular disease or disorder they might have with the eyes. And then if someone is psychotic, we need them to be able to at least have some degree of being able to make an adjustment in their affect. We wouldn't want to use folks who are actively psychotic.
Okay, thank you.
Okay. Anything else from anybody? Even insults?
Well, Steve, I will say, I'm sure I speak for everyone. This was a great learning experience.
I hope so.
Nurse practitioners have to obtain the same amount of training. It is a difficult course. It takes a lot of time. So if you have a therapist that does EMDR, hold them in your hand, oil them, because, and Steve, maybe you can answer this. I don't know how many therapists go on and get the additional training. I have a difficult time of finding therapists that do EMDR. And Steve has always taken my underinsured patients or my patients that are on Medicaid or Medicare. He's always taken them. So we have a good working relationship.
Absolutely.
I would encourage you to, when you get into practice, to find out which therapists in your practice or in your organization do EMDR, because it is a lengthy certification. And to have an expert in it in my own organization, actually down the hall, about 4 doors down,
Yes.
is a blessing, because I would refer a lot of patients with trauma his way.
And Brandy, EMDR, you can look them up and they'll give you the list of all the people that have trained or are certified. And I can tell you around here in the last 4 years, it has exploded. How many clinicians are coming out of graduate programs and immediately getting training in EMDR because it works.
Mhm.
You know, you will see a definite reduction in the way and the intensity of the trauma impacts the clients. You'll measurably see it. And they have, most importantly, they will experience it. So.
Yes. Well, thank you, Steve. It has been a lovely hour. I've been listening, been taking notes. So I just thank you for taking the time to state and explain. It was a lovely presentation.
Thank you.
And
Appreciate it.
our next open lecture series is Monday, May 17th at 3 p.m. And it's going over long-acting injection. And Mr. Lindquist, Matthew Lindquist, will be doing the presentation. It's at 3 p.m. Central Time, the same Zoom link. So hopefully you can make that one as well. And otherwise, I'm going to end the meeting. And thank you all for coming. It's
Goodbye.
to see this many.
Thank you all. Thank you,
this much of a
Brandy.
turnout. Yes, thank you. Take care, everybody.
Okay, bye-bye.
Thank
Okay.
you.
Thank you.
Bye.
Bye.
Bye. Thank you all. Bye-bye.